Thank you very much and good afternoon. So I am going to talk about the model of predictive model for visual outcome in particularly pediatric patient in very young pediatric patient. It is important to know about the ocular trauma as well as in pediatric age group because visual outcome is not predictable like other because of comorbidity. We know that social and economical impact and there are a lot of financial and social loss. These are important challenges in the children, particularly comorbidity, and most important is amblyopia. So which are the predictive models available in the literature? One is ocular trauma score described by Kuhn et al. And another is classification and regression tree CRT analysis. These are designed in long back in 2004 but were not validated with the larger database. We investigated and we validated this. Both one is published in ophthalmology and second in JCRS. So OTS was validated in ocular trauma in pediatric cases. But because of shortcomings, the pediatric ocular trauma score was developed and we published that in Graph Archives of Ophthalmology considering the special aspects of the pediatric age group, and these were all discussed in this review article. So why toddler ocular trauma score? In case of toddler 0 to 6 year, visual assessment on presentation may not be possible. And toddler ocular trauma score was designed by Reed et al. But they considered 0 to 18 years of age and considered only on open globe injury. So we have tried to study this newer modality of prediction. This is a prospective cohort study and all cases less than 6 months follow-up were excluded. The OTS categories were from 1 to 5 and POTS from 1 to 5, so more severe to less severe. In case of toddler ocular trauma score, it was a 5 to 1, so again more severe to less severe. And ROC curves and area under ROC curves were analyzed comparing TOTS with OTS and POTS for all categories to know the specificity and sensitivity. To perform the statistical analysis, POTS and OTS were categorized in 2 to 5, well merged into low risk category and high risk category. So this is how we calculated the score calculation. This is basic described by Kuhn et al. So by row score and deduction within particular conditions. These are the modifications done in pediatric ocular trauma score where these two factors are included. One is the age and second is the wound location. So age and zone were included. And these are the score calculation for toddler ocular trauma score where presenting acuity is not important but clinical findings were important where wound more than 6 millimeter size, hyphema, lens damage, choroidal detachment and retinal detachment. Some of the score less than 1 considered was a good prognosis. The results, we did the 1630 cases out of which 618 were the pediatric cases 0 to 18 and we studied 124 cases under age of 6 years. So these are the age sex wise distribution and 25% almost were the open globe injury. The results, mean age was 4.6 years. Pre and post visual acuity, pre and post treatment were significantly different. There is no significant difference between open and closed globe injury and children aged under 2 years had poor prognosis. These are the comparative study of OTS and pediatric ocular trauma score, percentages of predicted and actual visual outcome, and the second table is having ROC area under ROC curve. So these are receivers operating characteristic area curves, area under which was calculated, and this slide shows for the poor prognosis category, we see that it is not significant, while here better prognosis we can see the area is larger and having better prognosis. These are the comparative study of various variables, particularly with TOTS with ocular trauma score and pediatric ocular trauma score. We could see that we did not find any significant difference in other than OTS2. This is the comparative summary, the ocular trauma score and pediatric ocular trauma score basically based on presenting visual acuity, while toddler ocular trauma score is presented with the clinical findings. And here it is from 0 to 5, are more severe to less severe condition. In toddler ocular traumas are 5 to 0, more severe to less severe condition. In conclusion, this is a novel predictive score, is more reliable than pediatric ocular trauma score and less specific and sensitive in high risk cases. The TOTS can be employed to examine the outcome in toddler in whom vision checkup is not possible at presentation. Thank you.
Excellent study, very innovative. Are you apply any method for you to correlate your clinical judgment, to correlate your clinical assessment?
I think these guidelines we have taken from article by Reed et al., which was published in JAPOS. So we have taken those things, but we made modification in age group as well as type of injury. They studied only for open globe injury for 0 to 18 years of age. We tried to implement that in 0 to 6 years of age because between 10 to 18 it is possible to examine the vision on presentation, which might not become possible for 0 to 6 years.
Okay, because amblyopia is one of the big challenges for us.
That is more important.
Any take-home message to the audience to overcome amblyopia?
Any trauma cases, the prognostication has to be done, and parents can be explained for all pediatric patients what child will regain the vision. For that, any of the convenient methodology should be employed.
All, anyone.
For anyone.